Hello, good afternoon, and welcome to the WAPC webinar, Leveling the Field, Completing the WAPC Levels of Care Self-Assessment Survey Without Pain. I am Eva Fassbinder-Brummel, and I will moderate today's session. Our objectives for today are to describe obstetric and neonatal levels of care, and also to identify the location of materials on the WAPC website. Our presenter today is my esteemed colleague Kyle Mounts, who has been coordinating the Levels of Care program for WAPC since 2012, and he continues to advance the WAPC initiative on regionalized perinatal care. Welcome, Kyle. This webinar is brought to you by the Wisconsin Association for Perinatal Care, WAPC, and there is our website and all of our contact information should you need to refer to that at any time. Before we begin, you, the audience, will be in listen-only mode unless you raise your hand. Note the hand icon in the upper right-hand corner of your screen. We do encourage you to ask your questions by speaking directly to the presenter using your phone or computer microphone. You can also ask or answer questions by typing them into the question field. I will relay those questions or answers to the presenter in the order received. If you do not see the question pane, expand your screen by clicking on that orange arrow in the upper right-hand corner. If we don't get to your question due to time constraints, we will respond via email following the session. If you have any questions following the session, you can email them to wapc@perinatalweb.org. And if you are having any technical problems seeing the presentation or hearing the presentation, it is best to contact Barb directly at the email address or the phone number that you see there. All right, and with that, I'm going to turn things over to Kyle. Go ahead, Kyle.
Okay, and thank you, Eva. It's really a great pleasure to be here this afternoon talking about this. This is a topic in which I've had a tremendous amount of interest over the years because of how it relates specifically to the aspects of perinatal care. When I think about levels of care today, in 2016, in addition to the concept of standards of care that we'll talk about during the presentation, I'm thinking more now about the idea of what's considered risk-appropriate care. And as I hope you'll see during this presentation, there's real value to patients, families, facilities, and society in general when we can assure that care needs and provider resources are appropriately matched. Now, I realize that perinatal care really exists on a continuum, and when we talk about delivering care, we're also talking about a continuum too. When we talk about the levels of care, though, one way that I think we can consider this, that we can look at these ideas, is to think of them as the rungs on a ladder. If you're at a certain level, you have a reach that goes to a certain point. As you move up the ladder, your reach extends, and you always want to make sure that wherever your reach is, that it's done safely, and so it is with perinatal care. Now, before we start getting into the WAPC levels of care self-assessment process, I think it's good to get an idea of the history, because as we go back the 40 years or so that we have been looking at levels of care, it's important that many of the goals have remained the same, and the biggest one is to assure the best outcomes for moms and babies. So our story for this today starts in 1975, when the Committee on Perinatal Health, composed of representatives from the American Academy of Family Physicians, the AAP, ACOG, the AMA, and March of Dimes, published Toward Improving the Outcome of Pregnancy. The committee described the concept of regionalized perinatal care in this way, and I'm going to read this to you. Regionalization implies the development within a geographic area of a coordinated, cooperative system of maternal and perinatal health care in which, by mutual agreements between hospitals and physicians and based on population needs, the degree of complexity of maternal and perinatal care each hospital is capable of providing is identified so to accomplish the following objectives. Number 1, quality care to all pregnant women and newborns. Number 2, maximal utilization of highly trained perinatal personnel in intensive care facilities. And number 3, assurance of reasonable cost effectiveness. many things, many of those we can still see today, this is an aside, as being important. This particular document identified 3 levels of care. By the late 1970s to early 1980s, regionalization was recognized as the future direction of perinatal care. Regional perinatal centers were identified and established, and they developed formal relationships with smaller community hospitals, and arrangements were made to transfer high-risk women antenatally or newborn infants if they required a higher level of care. During that time, there was this huge influx of, or outpouring of literature that supported the concept of regionalized care, showing improvements in outcomes. It was a far improvement from where things had been before, where each institution tried to stand on its own and be all things to all patients in the area. Now, if you think visually, one way to think about this whole concept of regionalization is the idea of the hub and the spokes, where the perinatal regional center was at the hub, and then these spokes went out to the referring hospitals, again in a geographic pattern. As we go through these first few slides, I'm going to go back and forth between what's happening nationally and what's happening here, what was happening here in Wisconsin. WAPC published its own Toward Improving the Outcome of Pregnancy in Wisconsin in 1983. This document identified minimum capabilities for hospitals at the primary, secondary, and tertiary levels. A committee in each region was to implement planning, coordination, and communication, develop consumer and professional education, assure continuity of care in managing the continuum of perinatal services and hospital-based perinatal services in general, and also to develop methods for perinatal data collection. In 1991, WAPC followed up this document with directions in perinatal care, which specifically addressed public information and education, access to care, patient care guidelines, criteria for classification of hospitals, community health, and professional education and communication. Throughout a lot of what's happened with perinatal care, and some of you may be familiar with this, there's a book called Guidelines for Perinatal Care. It has been published roughly every 5 years jointly by the AAP and ACOG. And throughout the time, chapters have changed. They've evolved as our understanding of perinatal care, as our needs have changed too. The beginning of each book tends to focus, though, on the organization of perinatal care, and it's to these sections that I'm specifically going to refer as we look at this slide and consider some of the history. Now, in 1997, AAP and ACOG published the 4th edition, as you can see on the slide there. Now, on page 4 in this, the AAP and ACOG authors recognized that financial and marketing pressures were contributing to a change in the landscape of perinatal services. Getting away from the idea of hubs and spokes and stuff like that, there was this idea that marketing forces were now encouraging some hospitals to raise their level designation for perinatal care services. And sometimes this was done in an unbalanced manner, where obstetric or neonatal services may have been a level that was not matching the level of the other services. And you can appreciate some of the difficulties that could arise, for example, if a hospital decided they wanted to provide a very high level of maternal services, but only provided basic neonatal services, because certainly associated with high levels of maternal services are an increased risk for the infants. And so you need the level of care to go along with that. In addition, there was perhaps a breakdown of some of the classic regional coordination during this time. We were already seeing some of the changes, some of the evolution that was going to take place. Now, the 4th edition opted to use the functional descriptions that you see on the slide, the basic, specialty, and subspecialty care. And that's where I'm going to close that discussion on that one. 5 years later, 2002, AAP and ACOG published the 5th edition. Now, despite the efforts to go with the functional classifications that you saw in the 4th edition, many people were still using the numerical values, the idea of levels 1, 2, and 3. So in response to this, in the 5th edition, you will see both of those denoted. And in addition, the 5th edition also introduced the concept of the Regional Subspecialty Perinatal Healthcare Center and identified 2 primary goals for this center. One, to provide comprehensive perinatal healthcare services at and above those of subspecialty care facilities. And number 2, to be responsible for regional perinatal healthcare service organization and coordination, including maternal and neonatal transports, perinatal outreach support, regional education, research support, evaluating new strategies, and analyzing and evaluating regional data. Structurally, the book at this time combined descriptions of both the obstetric and neonatal services in the same sections. In the 2007 version, this changed. This 6th edition brought specifically changes in the neonatal designations, and some of you may remember some of those changes. We went from the idea of 3 levels to 6 for neonatal ones, and these were numbered level 1, levels 2A and 2B, levels 3A and A, B, and C. Now each of these, of course, as you go farther down the list, involved responsibilities for a higher level of care, a greater level of services for infants. The obstetric parts of this remain the same, and so for our purposes at WAPC, we continue to use the basic specialty and subspecialty designations to designate obstetric levels of care. The most recent edition of Guidelines for Perinatal Care was published in 2012. In this one, AAP further refined what they were considering their neonatal levels and went with a 1, 2, 3, and my slide doesn't have the 4, but it should. So 4 levels of neonatal care, while the obstetric levels still were in the categories of basic, specialty, subspecialty, and then a poorly defined regional subspecialty level. Now, these next 3 slides are going to focus on 3 articles, position statements, policy statements that have come from AAP for the first 2 and ACOG for the 3rd one. Under the publications of Guidelines for Perinatal Care, you can possibly appreciate that there's this slow sinusoidal wave where, since these are published every 5 years, there'll be changes and then those will evolve over time. But punctuated throughout that period of time, there have been publications that have drastically changed the amplitude, if you're thinking about this as in that curve kind of thing. But anyways, things that shake what's going on there. And so we're going to talk about some of these. The first of these articles, the 2004 one that you see here, and what I want to do is focus on the objectives specifically, and those are on the slides, because I think this gives us a good sense for where people were with their thinking about levels of care and the importance and perhaps the response to the changing environment as well. So we see here the first objective: review the current status of designation and the association of the designated levels of care of the site with neonatal outcomes. So that connection between level of care and neonatal outcomes was seen as important. Then the second thing was making recommendations for uniform, nationally applicable levels of neonatal intensive care based on the capability of facilities to provide increasing complexity of quality of care. Now, as I said, the first demonstrates the explicit need for outcomes, while the second strongly recommends standards by which all neonatal units could be measured and compared. Now, taking these objectives together, this statement sought to define the standards and obligations of units providing neonatal care. Let's fast forward now to 2012. The AAP releases another statement with the same title, Levels of Neonatal Care. This one happened to be published at the same time as the Guidelines of Perinatal Care, so you don't get any of that discrepancy that we have seen sometimes with some of the other ones where there's considerable time delays between the publications or time differences between the publications. Now, weighing the objective on the screen, note first of all the concept in the first bullet: comparison for health outcomes, resource use, and healthcare costs. So all of that turns on the importance of data and being able to understand these things. while considering 3 outcomes that are essential for our understanding and for how we are going to judge or evaluate care: health outcomes, resource allocation, and cost. Now notice the words used in the next 3 bullets: standardized, uniform, standards. What this is getting to the point where we're looking at how can we define these levels of care to make sure that we're all speaking the same language. We're here in Wisconsin, unless there's somebody from Minnesota here. When we talk about a level 1, we want that to be consistent across the state. Now, the bets are off if you cross over to another state, because we do not know how they're interpreting those same levels. Are they, for example, adapting it to meet their environment rather than upholding the standard that was set by AAP and ACOG? How are they interpreting that? Now, commercial standards, getting back to the title, leveling the field. In advertising, there are supposedly commercial standards that regulate the truth in advertising. Very important. And those standards are designed to assure you get what you're promised, so that if 2 people are saying the same thing, you can say, okay, these are probably the same kind of things. Shouldn't we have the same consideration when talking about perinatal care? Isn't it reasonable to expect that a facility that said it provides level X neonatal care services can and actually does do that? Now, 2015 was a red letter year for levels of care, because the obstetricians finally, and I apologize in advance to anybody who may be offended by this, but they finally got it together, and 11 years after AAP did it, came up with their own levels of care. And you see from the first 3 things there that those closely parallel what's happening in the neonatal services: uniform designations, standardized definitions, consistent guidelines. But where, to their credit, and where ACOG and the Society for Maternal and Fetal Medicine took it to a higher societal level, is with this fourth objective: foster development and equitable geographic distribution of full-service maternal care facilities and systems that promote proactive integration of risk-appropriate antepartum, intrapartum, and postpartum services. Now, it's interesting that as we look at these, the idea of a geographic definition or geographic constraints on this kind of care are not there. And what they're looking at is making sure that we can assure that care is being delivered where it has to be to the people who need it. Now, this takes us to the WAPC self-assessments process, and some of you may be very familiar with it. We got our start in 2006. We developed our self-assessment surveys after Colorado's. They were a leader at the time in what was happening with regionalized care, and we borrowed generously from them. We launched the self-assessment process the same year, and by the end of 2012, 65 of the roughly 100 birth hospitals had completed self-assessment surveys. In 2013, WAPC revised its self-assessment surveys based on the 2012 guidelines for perinatal care. And at this time, what we did was we separated the levels of care. Under the old system, the 2006 version of it, people completed one application and it combined the neonatal and the obstetric levels services in one document. Well, in 2013, we realized there's nothing that mandates any individual facility to provide the same level of obstetric services and neonatal services. So we separated those. So people completing the survey after that time completed a neonatal survey and an obstetric survey. And I should do it the other way to be consistent with how I've done other things, OB before neonatal. Anyway, in 2015, with the publication of ACOG and the Society for Maternal Fetal Medicine standards or levels of maternal care, we revised the obstetric survey. So currently, if you go on the website, and we will get to that to show you those, the current surveys reflect the latest information we have, the 2012 AAP ones and the 2015 obstetric ones. Now, over these next few slides, I'm just going to go over these briefly, what the different levels mean. For a more complete, for a full introduction to what each of these go, you can refer to any of the resources that are available, the articles that I mentioned, the guidelines for perinatal care. We have other things on the website. But level 1 obstetric services. The article from this year says they should have the capability to provide low-risk maternal care and readiness at all times to initiate emergency procedures, including the ability to begin emergency cesarean sections. They should also have support services available to make sure that if there are other things that come up during pregnancy, during labor and delivery, that those needs can be met. And there should be an established agreement with receiving facilities. And this is essential because people cannot practice in a vacuum when you're delivering care like this. You need those kind of agreements so that when things start going bad, if things start going bad, a one call is going to get you the kind of service, the kind of care, the kind of response that you expect and you need. Level 2 services obviously require all the level 1 capabilities, CT scanning and MRI, basic ultrasound for maternal and fetal assessment, so nothing real complex. And then if you look at the document from ACOG and SMFM, they talk about capabilities, and in the section right under that where they talk of types of healthcare, built into some of those types of the personnel that they need are also additional capabilities. So they talk about the availability of RNs with competence in level 2 care criteria and the ability to stabilize and transfer. And then medical and surgical consultants available to stabilize. Level 3 obstetric services require, again, the level 2 capabilities, advanced imaging available at all times, the ability to assist the level 1 and 2 centers. So it builds in that idea of the regional relationships or the relationships in general. Medical surgical ICUs able to accept the pregnant women and equipment and personnel for ventilation and monitoring on the unit until transfer to the ICU. Level 4 obstetric services, the highest level, again, have to have all the level 3 capabilities in an on-site ICU for obstetric patients, on-site medical and surgical care, and perinatal system leadership. So they're building into this idea that a level 4 should be more than just a place where you send all these patients to, but that it's an organization, a facility that can actually provide leadership. And part of that leadership involves the education, the getting back to the other facilities so that there's this ongoing focus on improving care overall. Then we turn to the neonatal ones. And in some ways, I think these have been defined certainly differently because there's perhaps less of a gray distinction in some of these, but level 1 neonatal facilities should provide neonatal resuscitation. Indeed, any place that's delivering babies should be able to provide that basic skill. When you get to higher levels of resuscitation, you don't need necessarily a neonatologist or somebody like that there, but you need people who can follow the criteria, follow the guidelines that are recommended to make sure that it's an effective resuscitation. They should be able to evaluate and provide care to stable term infants, stabilize and provide care for stable 35 to 37-week infants, and stabilize ill and less than 35-week infants until transfer, so fairly straightforward. When you get to a level 2, again, they should have the level 1 capabilities, but here the AAP was pretty strict about the gestational age and birth weight. So you see provide care for infants greater than or equal to 32 weeks and greater than or equal to 1,500 grams. In addition, they should be able to provide mechanical ventilation for brief periods of time or CPAP or both, and they define the brief period, the brief duration, as less than 24 hours. They should be able to stabilize any infants outside of that criteria until transfer, and also provide care for infants after an ICU stay. And admittedly, this is an area where many of the level 2s have not gotten a chance to perform because they just might not get the babies back from the NICUs. When you look at level 3 neonatal care, again, you see the level 2 capabilities, but there's also now moving it below the gestational age to less than 32 weeks, less than 1,500 grams. It includes a full range of respiratory support, including high-frequency ventilation if needed. the availability of advanced imaging, and providing prompt and readily available access to a range of specialists and subspecialists. And now in 2016, they don't have to be on site for level 3 standings because things like telemedicine have made many of these subspecialists as close as the room next door, because you can contact them, you can give them the information and get their input that way. Now contrast that to level 4. They need the level 3 capabilities, but they have to be located within an institution capable of providing surgical repair of complex congenital or required conditions. And for many of those, you need the surgeons on site for that, because it's not something that potentially can wait until a later time. So that's what distinguishes a level 4 from a level 3. They also need to have the specialists and subspecialists on site. And finally, they should facilitate transport and outreach education. Again, the idea of what's going on, spreading the knowledge, democratizing knowledge. Now, covered a lot of stuff there. For those of you out there who haven't done this or are thinking about, gosh, how do I know which level we potentially are? We put together this little graph or this table that gives like basic information about it. Now, obviously, the self-assessment surveys contain many more questions than just this, but this can at least get you into the right ballpark. Now, to start with, though, if your facility has done a level of care self-assessment before, maybe it'd be reasonable to just look at the comparable level and see if nothing has changed dramatically, see if those things still apply. But if there's any question or if it's a first time, these are some basic questions that can at least get you close to the self-assessment survey you need. First of all, do you provide low-risk maternal care? Can you provide an emergency cesarean section within an appropriate time? And we don't have I can't tell you 30 minutes is an appropriate time or an hour is, because the jury is still out on that in the literature. What is an acceptable time? Traditionally, there's been the use of 30 minutes from diagnosis, from decision to incision, I think it's the way they call it. But when you look at the literature, it may not be 30 minutes. It may be longer. So that's why they use the term an appropriate time. If you can do those things, every reason to believe you could probably meet the requirements for level 1 designation. If you provide basic ultrasound for maternal and fetal assessments, if there are medical and surgical consultants available, that could be enough to qualify for level 2 designation. Is there ICU care available to pregnant women? Are subspecialty and patient consultations available? That's level 3. Is there on-site ICU care? Is there perinatal system leadership present? Are there on-site specialty and subspecialty consultations? That's what distinguishes a level 3 from a level 4. Looking at the neonatal ones, we have the same kind of basic questions. Is neonatal resuscitation available at every delivery? Can the facility provide care to term infants and stable infants between 35 to 37 weeks? That's the essence of level 1 neonatal care. If a facility can provide care to infants greater than or equal to 32 weeks and greater than or equal to 1,500 grams, that's the basis for level 2 care. And are there provisions, are resources available to provide brief duration of mechanical ventilation or CPAP or both? Less than 24 hours? If so, that's level 2. Now, for the facilities that can provide care to sicker infants, those less than 32 weeks, those less than 1,500 grams, they could meet the criteria for a level 3 designation. Is there access to specialists and subspecialists, either on-site or by telephone or by telemedicine? Is there a full range of respiratory support? And finally, for level 4, can surgical repairs of complex congenital or acquired conditions be met on-site? Is there on-site access to specialists and subspecialists? If yes, that's a good reason to look at the level 4 neonatal services. We're going to look at some of the surveys now and go over some examples so that you can get a feel for what these may be like. We've modified the forms that used to be pen and paper. You'd mail them back, we'd make copies and send them out. We now have a fillable form that you can save electronically and then just email it to us to review. All those things are found on the website. Here's the link to that, and I'm going to go to that in a moment. And we're going to look right now at the forms, specifically the application form, which is required, and we're going to look at examples of 2 self-assessment surveys. Now, to see where they are on the website, let me pull that up. This is the WAPC website. Some of you may be familiar with that, perinatalweb.org. To get to the levels of care, it's under the major initiatives, which you see right next to the WAPC logo, and then you can scroll down until you get to perinatal levels of care. There are 4 sections under this heading, and what we're going to do, if I can get to it, is go down here to resources. When we go to the resources page, we see the cute baby at the top, and we see the title, perinatal levels of care resources, and self-assessment materials are first. I just rearranged these yesterday to make it that way. The first thing we're going to look at is the application form. And then as you go through this, you have a choice of choosing an obstetric services self-assessment survey and a neonatal services self-assessment survey. This appendix here, the staffing ratios, is now optional. We recommend it, but what it does is gives you a chance to take a look at how many nurses, what kind of staffing do you do for different kinds of patients, pregnant women in labor, postpartum women, the mom-baby dyad, sick babies, etc. But anyway, I've got a copy of an application form right here. You see what it looks like. Again, these are fillable fields. We see the hospital name and address, contact information, the person who coordinated the self-assessment process. And for those of you who can remember TV in, the 80s, will recognize these as being characters from the TV show, the hit series St. Elsewhere. We promoted Wayne and Jack Morrison and Helen Rosenthal. We ask for this statistical information, and what this does is give us an idea of the numbers of babies that are actually being delivered at these hospitals. And then you have the option of selecting the level that you're considering, levels 1 through 4, or my facility does not provide obstetric services, 1 through 4 for neonatal, or it doesn't provide that. And then if there are things that you need to explain more, does your facility have all the capabilities listed on the level you have indicated? Yes or no? If no, be good to know about those kind of things for whatever reason. If your facility does not fit into one of the proposed levels of care, please explain how would you describe your facility and why in the space below. And since we've been doing this, I have not seen anybody fill in this section, so most people can identify a level of care. The signatures are important. This section here. First is the person who facilitated the process, and then we want a signature of a facility or system CEO. And what this says is that there's buy-in at a high level in the facility for this process. In some cases, the facility may designate somebody, in which case you would complete this section here, and that's the application form. Now, the next thing we'll look at is the obstetric level of care self-assessment survey. So we can pretend that I just went to the website and just downloaded this form. I would recommend immediately saving it someplace on your desktop or in some appropriate folder, because there are some forms, unless you do that first, it doesn't save what you entered in. I think the state income tax forms like that or something like that. You have to do those kind of things. But anyway, all the forms, all the level forms are set up the same way, so that you've got the title, the level of services that it covers, and then we have these categories, additional comments, references, and GPC refers to the Guidelines for Perinatal Care, 7th edition with the page number. If it says Menard, that comes from the ACOG, Society for Maternal Fetal Medicine, Maternal Levels of Care article, position statement, policy statement, so that if you ever wanted to look to see where these came from, you could go back and do that. And then we have these radio buttons for yes or no, and they should all work appropriately now. But the general format for all these forms is the same. We start with the administration as level A, letter B is staffing, letter C are services, have to scroll down a little bit farther. Letter D is education. Letter E is quality assurance. Letter F is policies, procedures, and protocols. And then there's a space for comments. Like if you say you don't have something, you can comment on that if you feel a need. So we put that in there, and occasionally we do get things in there like somebody may say, we don't have neonatal services at our facility. All babies are transferred to another location next door, or something like that. So you can provide other information that way. So I went through and filled these out, but what you can do is if you start one of these and then you say, oh no, actually that's wrong, you can go back and you can change it and then save it again. As you can see from looking at this, you may have to get information from a range of sources. So you might go to like the nursing director for this stuff here, down here in letter B, number 2. Might have to talk to the obstetric, the director of obstetrics, the medical director of obstetrics for some of those kind of things. And then just go down through the various things. You'll see obstetric components, and you can at your leisure go through more of these, but it provides the things that are outlined in the guidelines for perinatal care in the recent ACOG SMFM paper for the various services and things like that. Then the next thing you would want to do is turn your attention to the neonatal ones. And again, it's set up the same way so that you have the same categories, the same letters A, B, C, D, E, and I think F, right? But it specifically applies to the neonatal stuff. And where there are comments, like some of these kind of things, we bolded this, at least one person whose primary responsibility is for the newborn and who is capable of initiating neonatal resuscitation should be present at every delivery, and that comes from ACOG and AAP jointly. In this situation, I checked the no box here. What that's going to mean is it's going to generate some questions. We're going to ask about that. We're going to send a response that says, you checked no in this particular thing. Who's there to provide care for the baby? And maybe what it is, oh, well, we have somebody there. They're all trained in NRP, but they may, we just didn't think about them in that capacity. So what this does, if nothing else, is gets people thinking about what should be available as you go through, as you're providing perinatal services, and in this case specifically the neonatal ones. And so those are the forms. And again, all of them are set up the same way. The level 4 forms have considerably more pages. I think they're on the order of like 5 or something like this. You can see I put a comment in there. We provide level 2 care, but we don't take care of babies. And if I'm reviewing this, if I'm looking at this the first time, I'm going to say, that's interesting, because according to AAP, you should be able to provide care for babies greater than or equal to 32 weeks. Okay, let's go back to the slides here and see where we are with that. Okay, frequent issues. There are a number of things that frequently come up with these that we are oftentimes contacting the facility contact to relook at. The first of those are signatures. If there's not a signature from the CEO or the CEO designee, we're going to contact you to see about getting that kind of signature. Because again, we want the assurance that this is something that's being accepted and recognized at the highest level of the facility administration. Sometimes the self-assessment surveys aren't complete. People will miss a box. That's not a big deal. Just send an email and say, we noticed you didn't check this box. Do you provide this service? And then they email back, oh yeah, we do. Sorry about that, just forgot about it. And I say, okay, and I make note of that. One of the things that we sometimes see, and these 4 right here are worth discussing a little bit more, and I'm going to go back to the obstetric one to show how we've addressed some of those. So let me go back there. And these are all in this section on page 3 of this particular one. You see here, under education, it says regularly scheduled multidisciplinary conferences at which patient care issues are presented and discussed. AAP and ACOG do not go into a lot of details about how this should be accomplished. So what the levels of care review team did was took a look at how this particular criteria could be met. And we decided that there are a lot of different ways that people do this, perhaps without even realizing it. It can be the quality committees for obstetric and pediatric services. It could be the discharge or follow-up planning groups, multidisciplinary rounds, case conferences, the M&M conferences. So there are a lot of different ways that this particular criteria can be met. And so many times, if this is checked as no, we will contact the contact and say, do you have these things? What about this? How do you handle these situations? To try to get an idea of what actually happens at a facility. The quality assurance issues are big ones. Data collection, storage, and retrieval. And if the facilities are using Peridata, it's all right there. There are other things too that can be useful, like for the level 3, level 4 NICUs. There could be involvement in things like the Vermont-Oxford network, things that allow you to actually track that data. And it's important, tied in with that data, to consider what's happening with quality improvement programs, because it should all be about maximizing patient safety, improving patient outcomes. And unless we're collecting this data, unless we're doing something with it, we're not necessarily going to be changing anything. We're not going to be looking at how can we make this better. You know, anytime, if it's a sports team, no team is going to be happy the Denver Broncos won the last Super Bowl. They're not just going to sit back and say, you know, we can pass on all of our draft choices this year because we had a darn good team this year and I think we can do it again. No, they're going to look at how they can make next year's team even better, because that's always the goal for that. It's always the goal for healthcare, improving the outcomes, doing better. Policies, procedures, and protocols, and we have, and I realize there are differences in the definitions of these things, but the idea is, how do you standardize these various things there? What do you have to fall back on to make sure that you're doing the best that you can? How do you make sure that the new people coming in know what they should be doing? And that's what that's about. So those are the frequent issues we have. There are some other useful documents, and we'll go back to the WAPC website for those, and I'll talk about those a little bit more. Okay, so we talked about the self-assessment materials. Just beneath those main ones there, we have this section called supplemental surveys. Now, as you recall, there was a little bit of a time discrepancy between when the 2012 Guidelines for Perinatal Care was published and when ACOG and SMFM came up with the maternal levels of care. So what these supplemental surveys do is they've taken the things that were included in the 2015 document and highlighted those so that somebody who wants to look at, who maybe completed a self-assessment survey before 2015 can update their information that way. So if we were to click on these, we would see the exact same self-assessment survey, but we've taken out all the boxes that we don't have to ask again because those were covered in the initial one. And what's left are just the ones, and it's usually the things that are references in the reference under Menard, because that's when that stuff came out, and we'll talk a little bit more about Kate Menard. The next section on the website are the references. And I put 4 things on here that I've talked about already during the presentation. The first is the current edition of the Guidelines for Perinatal Care. If you do not have this in your nursery, in your obstetric unit, or someplace where it's available, I would suggest doing it. It's got a tremendous amount of information in that, and we've just been covering the things related to the organization of perinatal care. There's a lot about transport. There's a lot about facilities and what's required there and things like that. It's worth looking at. The next 3 are articles, the position statements from AAP, Levels of Neonatal Care, and then this from ACOG, Society for Maternal Fetal Medicine, and Kate Menard, Levels of Maternal Care. And those are all there, and they're worth looking at, especially these 2. The 2004 one is good from a historical perspective, but for the most recent stuff, you want to turn to the 2012 copy of it. The recommendations for developing a guideline or policy regarding consultations for the care of high-risk pregnant women. This is a document that the review team developed in response to facilities' requests for, you know, how do we know who should be handling these patients? Because we could probably agree that there are some patients that require a higher level of expertise. It might be a 24-week infant where you'd prefer that somebody with maybe subspecialty training in neonatology to provide care for that infant. And it's important for facilities to recognize that there are levels of risk for pregnant women and for infants, and that there are levels of qualifications for the providers that can provide the care. And so making sure those are matched appropriate is important. I won't talk about levels of care summary. Some of these things I'm going to update. We also have the guidelines for the responsible utilization of neonatal intensive care. That's the position statement that WAPC revised and updated. I think it was last year, 2014 maybe. Anyway, that's in there too. So if you provide care to infants, and you're interested in some of the social or ethical economic issues involving neonatal intensive care, I would encourage you to look at that publication. So where are we now? Just a few words about the review team. It is a well-defined structure here at WAPC. It's comprised of members representing different specialties, disciplines, and regions in the state. We have a requirement that to review level 1 or level 2 facilities, we need at least 3 members present for the review. If it's a 3 or 4, we need 5 members for a quorum. The process itself, if you submit a level of care self-assessment survey, the first person to take a look at it would probably be me at this point. And what I do is go through, I check for the signature of the CEO, I check to make sure that every single one of those lines, the criteria, the services, has a yes or a no checked in there. If I have questions about it, if for example, there are things that are incongruent, like, well, I won't come up with an example this quickly. I should have thought of that before. But anyway, I'll ask. I'll send an email and just say, you know, for clarification, can we get this kind of stuff? So that then when it goes to the review team, they can act on it, hopefully as efficiently as possible. All the assessments are blinded. I'm the only one who knows who they come in currently, who they come from, and what they say. Because when we deliver those, you saw the forms, there's nothing on there that's identifiable. And if there is, like somebody says that our hospital is next door to hospital X, and we just send all of our sick patients over there, I redact that so that it's not present, so that these are blinded. Because we recognize that there's marketing competition for facilities, and facilities that can advertise a higher level of care might be seen more favorably in a community, and we don't take sides with any of that. When the review team reviews the completed assessment, they generally will come up with one of 2 conclusions. One, to accept it, and the other is to request more clarification. There might be specific things that I didn't think of or that I didn't look at that come up. And so then we contact the contact again to ask for that clarification, and then bring those clarifications back to the review team. And then finally, a staff member updates the list that we have on our website. This is the address for that, and I'll show you how to get to that and describe how we have things signified on this particular page at this point. So let's go back to the website. Okay, so I've taken us back to the resources. It's under perinatal levels of care under the category what we are doing. So if you click on that, you again see the baby in the header, and it's what we are doing. And as you scroll down, there's a description of the self-assessment process, and then a link that takes you to the process results. So this opens up a new page, and because of this process evolving over time and using different criteria, we've divided the facilities that have completed self-assessment surveys into 3 tables. The first table shows those that are current on all the recommendations, and those are the 2015 obstetric levels of care and the 2012 neonatal levels of care. If a facility is in that category, we don't recommend any update, because they are all up to date as much as possible. If a facility completed the designations reflecting the 2012 obstetric and neonatal levels of care, remember the big thing was how the OBs define things. So that's why in this particular one, you see for obstetric services, it's got a functional description basic, specialty, or subspecialty, and the neonatals are a 1 or a 3. If your facility is in this table, we recommend going to the Obstetric Supplemental Self-Assessment Survey, and this link will take you back to the resource page because I don't know which one of those you want. So you're going to have to go down through and say, okay, we did a basic one before, so let's update it using the level 1 supplemental survey. Now, there are 20 hospitals listed in there. The largest category are those that completed the self-assessment process under the 2004 criteria. And as we said at the beginning, there have been significant changes in how we've looked at these, both in terms of neonatal services and obstetric services. So if your facility is listed on this particular table, we recommend that you go to that resource page and take a look at which one would be appropriate. If you're from, actually I won't mention any names, but you can just look at these things and make the decision, okay, I think that we probably qualify as a level 2. Let's fill out that self-assessment survey and take it from there. And so that's the information that you have. We consider putting hospitals on here that have not done anything at all with it. But the problem is that if there's a small hospital in a small town that just started doing deliveries, we may not know about them. And so we don't want to exclude them for that reason. Okay. Future directions. Wow. As we move forward, we're going to have to ask ourselves at least one very important question. How do we define or redefine the concept of regionalization? Historically, as we saw, it was based on a geographic foundation. In the 1970s, there were 6 NICUs in Wisconsin, and they had these connections to the hospital in their geographic areas and things like that. But things have changed since then, and we're now looking at other things that can define these barriers. Look at the hospitals in Wisconsin now that are part of systems that have home offices outside of Wisconsin, places like in Illinois or Iowa or Minnesota. And so what happens in the, when we're thinking about regionalization in those states, or how do they handle that? As a corporate office in Iowa, for example, if we think about regionalization and the traditional things about geographic areas and things like that, crossing state lines is not, it's not an easy thing when you're looking at things like payment and stuff like that along the way. Now, despite these geographic changes, there's still considerable value in identifying levels of care based on risk-appropriate services or risk-appropriate care, and expecting facilities to have relationships with other facilities that provide higher levels of care. In addition, and in order to assure facilities providing lower levels of care provide the highest level of care they're able, it's imperative the support for these lower level facilities is provided, is coordinated by higher level facilities, so that they're not just thinking about themselves and the patient volume and things like that, that they're looking about how the system can improve to meet the needs of the moms and the babies. Further, it's absolutely necessary that all facilities engage in active quality improvement initiatives. In 2016, that's the way it is. You know, you can't go any place without hearing about quality, without seeing it. If you're on the IHI list, you get emails every single day about their latest this, their latest program regarding that, their latest conference and things. Now, one way facilities can do this in Wisconsin is participating in the newly developed Wisconsin Perinatal Quality Collaborative, WISPIC. The seeds of this were sown probably in 2014 or so, and they really sprouted in 2015 when WAPC was awarded a grant from DHS to develop the infrastructure for WISPIC. Some of you may be familiar with it if you went to the regional forums last fall, launching the first initiative of the collaborative on hypertension in the perinatal period. That's where it started, but that's not where it ends. And we have plans for this to expand to make sure that we're addressing the needs of moms and babies, and that we're extending this not only into the hospitals, but also into the community, into the public health realm, so that we're looking at quality broadly the way it should be. For information on that, you can go to the website, and there's an initiative. But if you go to the major initiatives, at the very, very bottom, you see the WISPIC Perinatal Quality Collaborative, and it provides information about it and how you, as a facility, can join it. This is open to organizations, not individuals, because we recognize the importance of organizational buy-in and involvement to make this truly successful. So with that, I'll turn things over to Eva to moderate discussion for the next couple or 3 minutes on questions and comments. Eva?
Thank you so much, Kyle, for that excellent presentation. So much great information for facilities. We don't have any questions at this time. And I haven't seen any come in. But this is the time, if you have a question you'd like to write in, or if you want to raise your hand, please feel free to do that. We do have a couple of minutes left. And so while people might be thinking about that, Kyle, not to put you on the spot, but I'm wondering, can you talk a little about like what are some of the most common questions that you get from facilities as they are going through this self-assessment process?
The biggest one probably relates to level 2 neonatal services, because I think you could make a strong physiologic argument to why AAP should have looked at 34 weeks as a cutoff for level 2s, but they went with 32. And that for a lot of facilities presents an issue because they provide high quality level of care, but they're not taking it down to that 32-week gestation, which AAP says is needed for a level 2 nursery. And so a lot of it relates to that kind of stuff. And the question, and some of it specifically gets to the respiratory component. If you are going to provide things like CPAP or mechanical ventilation, it's absolutely necessary that somebody has to be there who can handle emergencies like a pneumothorax, because those can happen at any time. And if you have a child with a pneumothorax, if it's not recognized and treated appropriately, it could end in death for the baby. And so you need those kind of things there. So it's those kind of things that do it. There are a lot of things. We've had some good conversations with facilities, some of which have looked at their level of services and said, you know, we are going to do that. We are going to raise that bar because that's what we want to deliver. And others have said, we can't meet those standards. We're going to be the best, thinking if they were level 2 under an earlier submission, we're going to go with level 1, but we're going to be the absolute best level 1 that we possibly can. And there's absolutely nothing wrong with that at all.
Great. Thank you so much. So with that, I think we're going to wrap things up. So if you have any questions while you're completing your self-assessment survey, make sure to shoot an email to Kyle or give him a call, and he's more than happy to go through any questions that you might have and help facilitate the process. Also, please remember that if you are not already a member, to join WAPC or also renew. This is a great time to renew because you can, in one fell swoop, register for the 2016 annual conference and renew or join your WAPC membership at the same time. So please make sure to check out our conference website listed there, wapcperinatalconference.org, if you haven't already, and make sure to register for the conference. Also to let you know that this presentation has been recorded and it will be archived on the WAPC website in the perinatal levels of care section, and we will send out an email when we have that up so that you can share that with colleagues or watch again if you need to refer to it. All right, well, thank you so much for attending today, and thanks again to Kyle Mounts for facilitating this presentation. Good afternoon.